All right, let's dive into a topic that every single clinician needs to master: H1 antihistamines. We're going to be correcting some really common myths and making sure our protocols are sharp, up to date, and based on solid evidence.
Okay, we're jumping right in, no messing around. Here's a scenario you are absolutely going to face. You've got a 35-year-old patient, 12 weeks pregnant, and she's dealing with daily hives. You see the options on the shelf. So what's your move? What's your first choice?
And look, this is way more than just picking a drug to stop some itching. The choice you make here has huge implications for patient safety, especially when you're thinking about things like teratogenicity and sedation. This is exactly the kind of nuanced decision that can show up on your board exams, and getting it wrong is a big deal.
So to really get this right, we've got to go back to basics. Let's talk about how these drugs actually work at the molecular level. And spoiler alert, it's probably a little different than what you were taught. We all casually call them histamine blockers, right? Or antagonists, but technically that's not the full story. They're what we call inverse agonists. So instead of just plugging up the keyhole, they actually bind to the receptor and force it into an off position, stabilizing it there. It's a subtle but really key difference.
So this slide just lays it all out beautifully. Histamine comes in, kicks off this whole cascade that leads to the swelling and the itch. But then, the inverse agonist swoops in and basically freezes that receptor in the off position. That car analogy is perfect. It's not just blocking the ignition, it's putting a giant boot on the wheel. The entire allergic reaction is stopped dead in its tracks.
Okay, so now that we've got the science down, let's see why this matters in the real world. This is where we get into a huge public health issue: the critical difference between first and second generation agents. So what's the big deal? Well, it all comes down to one key phrase: peripheral selectivity. The older first-gen drugs like hydroxyzine, they just barge right through the blood-brain barrier, and that's what causes all that heavy sedation. The newer second-gen drugs are way smarter. They're designed to stay out of the brain and just target the allergy symptoms. And believe me, this is not just some academic footnote. The official Bierce criteria, the gold standard for medication safety in older adults, flags these drugs as a major risk. Seriously, prescribing one of these to an elderly person who drives or is at risk for a fall, that's getting into what we call a never event in modern medicine. All right, time to get into the nitty-gritty. Let's talk about the specific drugs you're using day in and day out and bust some common and honestly pretty dangerous myths that are still floating around. Let's start with cetirizine. Here's a big board exam myth. A lot of people think it's a no-go for very young kids. Wrong. That's totally outdated. The FDA has given it the green light for children as young as 6 months old. Plus, as we'll see, it's one of the top choices for pregnancy. But, and this is a really important but, while it is a second-gen drug, it is not completely sedation-free. Check out that number. A good 10 to 15% of people will feel sleepy on it, and that gets worse as the dose goes up. You've absolutely got to mention that to your patients. Now, if you want something that's truly non-sedating, you're looking at fexofenadine. And here's your classic board exam question, the one thing you have to tell patients: no fruit juice. Orange juice, grapefruit juice, they can seriously tank the drug's absorption and make it way less effective. Oh, and just remember, it's category C in pregnancy, so it's not our first choice there. Okay, this next one is a huge clinical update you need to know about: bilastine. You might hear about it, it's popular over in Europe, but here's the deal. It is not FDA approved here in the US. And more importantly, you might see things online claiming it's safe in pregnancy, but the data just isn't there yet. So the best practice is simple: avoid it and stick with the drugs we know are safe. All right, so let's put all of this together. We're going to circle right back to our patient from the beginning and figure out the right call. So now we're ready. We have the evidence, we know the myths, and we can make a choice that isn't just a guess, but a clear, defensible clinical decision based on the best data we have. And the major guidelines from groups like ACOG and the AAAA couldn't be clearer. The top-tier preferred agents are cetirizine and the old-school first-gen drug chlorpheniramine. And why? Simple. They have mountains of human safety data. On the flip side, hydroxyzine is a hard no in early pregnancy because of some pretty scary animal studies. So there it is, the single best answer for our patient. You're going to start her on cetirizine, 10 milligrams once a day. It hits that perfect sweet spot of having the best evidence for safety in pregnancy and being really effective for her symptoms. Okay, let's wrap this up by turning all this knowledge into some hard and fast rules. We'll talk about protocols for those really tough cases and go over the most critical safety warnings one more time. This is so important.
If a patient's hives aren't getting better on a standard dose, your first move isn't to switch drugs or add steroids. The latest guidelines actually say you can push the dose of a second-gen antihistamine up to 4 times the standard dose. It's a powerful, evidence-based step you should take before escalating. Okay, everyone, listen up because this is probably the single most important safety point of this whole explainer. If your patient has hives, but also has a drop in blood pressure or any trouble breathing, that's not just hives anymore. That is anaphylaxis. And in that situation, antihistamines are basically useless. The only thing that will save their life is epinephrine. Period. So let's recap the big take-home never events. 1. Never, ever give a first-generation antihistamine to an older patient who drives or is at risk of falling. And 2, a crucial dermatology crossover. Never put a steroid cream on a rash you even think might be fungal. You can create a monster called tinea incognito where the fungus just goes wild.
And that leaves us with one final thought, something we're seeing more and more in the clinic. You have a patient who's been on cetirizine for years. They try to stop, and they get this insane, severe rebound itching. It's a real phenomenon. It just goes to show you, even with our most common drugs, there's always something new to learn. So, what's the mechanism there, and how would you manage it?